Hi, it's great to be here today. My name is Andy Brunner. I'm from Mass General Cancer Center up in Boston, Massachusetts. I primarily treat patients with MDS. And, I'm really excited about the new options that we have in treating this disease. We have an expanding number of ways to approach anemia in these patients. A big challenge for MDS, if you look at treatments of all MDS patients, historically, most would get EPO, and that's it. Very, very few people would get a second line of therapy ever. And most patients would only ever get exposed to growth factors. And what I view these data showing, and most patients would be put on growth factors and never stop. And these data to me suggest that, we have multiple active agents in MDS. A debate I have internally is if they're not prolonging life, how do I give each patient the longest chance of being responsive to treatment through potentially multiple lines of therapy? And so when I view the commands data, I can tell you, and actually to the point of, do we need to wait for people to become heavily transfusion dependent? I think we historically waited too long to initiate any therapies because we didn't want to run out of lines of therapy. But as we move ESAs earlier, knowing that we can quickly move on to luspatercept, that was kind of the shift recently. And now with the commands data, I suppose in my practice, I agree actually that I think luspatercept works in ring sideroblast positive and ring sideroblast negative patients. The effect size, the chance of response might be a little higher in RS positive patients, but that doesn't mean that it's inactive in RS negative patients. And the big debate I'm having in my mind is if you can use luspatercept more likely in a second line setting, should I not go early with EPO? And as soon as there's a transfusion need, or as soon as there's a lack of response, instead of keeping someone on EPO for ages with the idea that they might worsen if you stop, I know I can swoop in with luspatercept quickly when they hit 1 to 2 transfusions per month. And so I think that internally I'm having that debate. Should I go ahead, start EPO, start ESAs kind of in this even earlier setting than I used to, and then accept that, they're not going to work forever, and I have a great option as soon as they hit 1 to 2 transfusions a month, I can jump ship and go to luspatercept. And I think that the commands data to me suggest that we should not delay, and that's the big takeaway I have from all these agents. Don't let somebody become heavily transfusion dependent without trying different options. But I realize that's not exactly answering the question, but currently in practice, that's kind of how I've started to adopt it, is not belabor. Once people are not transfusion independent on EPO, cut ship early and go over to luspatercept when they're still needing only 1 unit of blood or 2 units of blood a month.